So it's generally believed that improvements in medication adherence will result in decreases in medical spending. This has been supported by a range of studies. This literature dates back more than 20 years. There's also been sort of large reports that have said that you can save up to $300 billion a year through improvements in medication adherence. So the belief is there that there is this relationship between improvements in adherence and medical spending. I think what it comes down to is how strong is that relationship? And that's a much more involved question to answer, because a lot of that depends on, okay, how do you define adherence and how are you measuring that relationship? So when you're looking at studies that have evaluated this, a lot of studies don't necessarily use populations that are sort of qualified for Medicare Part D STARS ratings programs for existing adherence measures. The data on those is quite old, at a time when only 50% of people would meet a proportion of days covered of 80%, versus today that's around 80%. It's just a very different sort of landscape for the existing literature, which means that when you evaluate the relationship today, you will get different numbers. But the relationship is still there. It's just sort of how strong is it. So non-adherence is a multifaceted issue. There's a whole range of factors that go into a patient's non-adherence. Some of the key ones that have been sort of looked at in the literature most are things like patient cost exposure. So we know that more expensive drugs are less likely to be filled initially, so that's talking about primary non-adherence. And when a patient does fill that drug initially, patients tend to stay on that for not quite as long. So that's an issue with secondary non-adherence as well as persistence. And so patient cost exposure is one large reason why people do not adhere to medication. There's also a range of personal factors. Some people are just simply more likely to adhere than others. Some people are more likely to uptake behaviors that are sort of healthy, right? Some people like to jog, they like to eat healthy, and they like to take their medicine, right? Those things sort of cluster together, and that is more difficult to account for, but certainly makes a difference in adherence. The ease of which a patient can access a medication also makes a difference with adherence. The importance of the disease to them makes a difference in adherence. I mean, this is trying to look at the whole range of factors is quite challenging. And then layered onto that, the ability to actually see these factors that influence adherence within medical claims is extremely limited. Like medical claims and pharmacy claims are very, very powerful. You can see a lot through that. You can see, again, use of all services. You have information on the member file, which is also useful, but you can't see the extent to which a patient wants to take their medication, or how concerning their disease is to them, for example. And all of those factors are important and are much more difficult to get at, certainly from the PBM perspective. Yeah, so the relationship between disease states and adherence is also quite complex. Some disease states that are more, we think of the concept as salient, right? So for example, if you don't take your medicine, you feel bad. That connection tends to make a person be more adherent. For example, diabetes, right? People who are less adherent to their diabetes medications, hyperglycemia has direct side effects that a person can observe in usually a relatively short period of time, depending on the medication, if they stop taking it. And so those sorts of disease factors tend to, again, prompt a person to be adherent. But if you look at things like statin use or antihypertensive use, especially cholesterol, like you just don't know if you have high cholesterol, like unless it's really, really high. You just don't have an understanding of what your cholesterol is. So this idea that you want to take something which might make you not feel quite great, that is supposed to reduce your future heart attack risk for something that you can't really feel right now, it's just a harder sell. So those sort of like, do I feel bad if I don't take it? Types of disease state factors can be very meaningful when it comes to prompting a person to be adherent or not. So when I think about sort of data, when I think about data needs for measuring adherence, I mean we can measure adherence fairly well using pharmacy claims. At least there's reason to believe that we can get a meaningful, if not 100% accurate measure of adherence. When we're talking about medical spending, medical spending through claims, it's the best source for it, right? We can see what is sort of billed and paid out on that. So those two pieces are sort of well established. Where data is needed is looking at sort of two things. One, predicting members who are going to be adherent or not adherent. Those predictive models do rely on a lot of patient factors which cannot be observed through claims. Like it would be really good to know, for example, social determinants of health, right? What is the structure of a person's environment that makes it more likely or less likely that they'll be adherent, or more likely or less likely that they can access medications in general? It'd be really good to know that. We can make some guesses through linking things like the census tract to a person, but it's hard to do that at the member level without more detailed information. So that's kind of the predictive modeling piece. The other piece of it is there are sources of confounding and bias that exist when trying to look at the relationship between adherence and medical spending. Some of that can be accounted for by using approaches that we would call them a fixed effects approach, using multiple panels of patients, and through that design can help to control for within-person effects that are consistent. So if a person is consistently more likely to take their medication or consistently less likely to take their medication, by looking at the same observations in the same person, you essentially account for those invariable factors, which is helpful, but you can never fully control for those. So getting some additional patient factors could help for estimating that relationship, but I think that there's a strong opportunity for especially like predictive modeling and potentially risk adjusting for it as well.